The term neoplasia can be divided into two parts. There's neo, which means new, and plasia, which means growth. So you would expect a new growth to be called neoplasia, right? Where you are not completely wrong. However, not any new growth can be called neoplasia. For example, let's say you get a wound on your arm. This wound gets covered up by the formation of new cells. That is, there is new growth of cells, but this new growth of cells is not neoplasia. Similarly, in a pregnant woman, the size of the uterus increases due to the increase in number of cells in the uterus, so as to adjust the growing baby. This right here, in this condition as well, there is new growth in the uterus of the pregnant women. But this new growth is not neoplasia. It is hyperplasia. So the question arises, when is it that you can call a new growth neoplasia? Neoplasia is a special type of new growth with defining characteristics. This is the important point. It has defining characteristics that makes it neoplasia. So what is neoplasia? What exactly is neoplasia? Neoplasia is an abnormal growth of cells that is number 1, excessive, number 2, uncoordinated, and number 3, persistent. The abnormal growth of cells has to follow all 3 of the given criteria or must contain all 3 of the given characteristics to be called neoplasia. Again, what is neoplasia? Neoplasia is an abnormal growth of cells which is number 1, excessive, number 2, uncoordinated, and number 3, persistent. Let's look at each of these characters. Number 1, excessive. By excessive growth, it means that the growth of cells is beyond normal. However, there's one problem. Let's take an example of pathological hyperplasia. Let's take an example of endometrial hyperplasia. During endometrial hyperplasia, the level of estrogen in the body of a woman increases beyond normal. As a result, there is beyond normal proliferation of the endometrial line. That is, there is beyond normal or excessive proliferation of the cells of the endometrium. At this particular condition, there is abnormal growth of cells and there is excessive proliferation of cells. However, it's not neoplasia. I repeat again, for an abnormal growth of cells to be neoplasia, it has to have all 3 of these characteristics, not one of them, all 3 of them. Number 1, excessive, number 2, uncoordinated, number 3, persistent. So excessive would be beyond normal proliferation of cells. Uncoordinated, the cells of neoplasia or the cells showing neoplasia are called neoplastic cells. And these neoplastic cells, they are independent. That is, they don't care about other cells. There is no coordination between the cells of neoplasia and between the cells of neoplasia with another normal cell. If you compare a normal cell with a neoplastic cell under a microscope, let's say you take a normal cell, observe it under a microscope, and then you observe the corresponding neoplastic cell of that normal cell under a microscope, you'll find that the neoplastic cell has lost its normal architecture. So that's uncoordinated. Number 3, persistent. In a normal condition or during normal cell division, the cell divides only when it gets a signal. Once the signal is snatched away, the cell stops dividing. However, in case of neoplasia, the neoplastic cells, they don't care about the signal. Even when the signal is not present, the neoplastic cells, they proliferate. So that's your neoplasia. It's an abnormal growth of cells which is excessive, uncoordinated, and persistent. Okay, let's say in your arm, a certain cell becomes neoplastic due to some reason and it starts proliferating. It ends up making a mass of cells, and this mass of cells is what you call a tumor or neoplasm. So tumor or neoplasm is the result of neoplasia, and it is of two types. You have benign tumor and malignant tumor. Neoplasm or tumor contains two parts. There's tumor parenchyma and tumor stroma. Tumor parenchyma are nothing but the cells of the tumor, the neoplastic cells of the tumor. And tumor stroma is the base or the foundation on which these cells lie. So you can see right here, here's a tumor, and these are the neoplastic cells of the tumor which form the parenchyma of the tumor. All other components other than the neoplastic cells, such as white blood cells, blood vessels, and connective tissue that form the base on which the neoplastic cells lie, form the stroma of the tumor. The significance of neoplastic cell or tumor parenchyma is that with the help or by observing neoplastic cell or by observing tumor parenchyma, you will be able to figure out whether the tumor is benign or malignant, as well as figure out the name for the neoplasm. That is, whether the neoplasm is a carcinoma or a sarcoma. What's that? You'll come to know soon enough. Desmoplasia. See, in neoplasia, I said that the neoplasm contains two components. There's the parenchyma of the neoplasm or the tumor parenchyma, which contains neoplastic cells, and then there's the tumor stroma, which forms the base or the foundation containing of blood vessels, connective tissues, and white blood cells on which the neoplastic cells lie. Here are the neoplastic cells. These are the neoplastic cells, and these neoplastic cells, they lie on a stroma. This is the stroma. This is the stroma, which contains your white blood cells, blood vessels, connective tissue. The difference between desmoplasia and neoplasia is that, see, the part desmo means connective. So the stroma, it is rich in collagen fibers. There is high deposition. There is high deposition of collagen in stroma. At that particular condition, we call it desmoplasia. For example, serous carcinoma of breast. Okay, one last revision. So what is neoplasia? It is an abnormal growth of cell which is excessive, uncontrolled, and persistent. The result of neoplasia is the formation of a mass of cells, and this mass of cells is what we call a tumor, which is the same as neoplasm. Tumor or neoplasm, it's of two types. It's either benign tumor or malignant tumor. Malignant tumor is what we call cancer. Let's see the difference between the two. Let's say here's a tissue. In this tissue, a certain cell becomes neoplastic. This cell starts proliferating. As it proliferates, it pushes the cells or the tissue at the periphery to the side. It pushes the cells to the side as the cells proliferate and grow. This tumor is benign tumor. However, in case of malignant tumor, the cell that proliferates does not just push the periphery cells or tissue to the side, it invades the tissue. That is, it penetrates through the tissue. Let's say this right here is malignant tumor, and this is the periphery tissue. This is the periphery tissue. The malignant tissue will penetrate through the gaps of the periphery tissue and proliferate and penetrate and invade everywhere possible. So that's how a benign tumor grows, by pushing the periphery tissue to the side, and this is how a malignant tumor grows, by penetrating through the periphery tissue. By now, we know what is neoplasia. We know that the result of neoplasia is a neoplasm, which is also called tumor. And tumor is of two types. You have benign tumor and malignant tumor. Benign tumor is such a tumor that as it grows, it pushes the periphery tissues to the side. Malignant tumor is such a tumor that as it grows, it penetrates through the gap of the tissue and invades everywhere. Now, what we need to know are the differences between benign tumor and malignant tumor. This we are going to learn on the basis of significant features that help us determine the difference between the two. So as you go down, you are going to find more significant features that is going to differentiate between the two types of tumor. That is, if rate of growth is the least significant criteria for determining whether a lump is benign or malignant, then the most significant criteria is metastasis. Again, the most significant criteria for determining whether the tumor is benign or malignant is metastasis. The second most is invasion. Fine, let's begin. Let's say a patient approaches you with a lump on his neck, or let's say you get a slide with a tumor. Then you have to determine whether that tumor is benign or malignant. Here are the ways you can determine by knowing the difference between the two. The first is rate of growth. A benign tumor grows much slowly as compared to a malignant tumor, and here is why. In benign tumor, the mitotic rate is low. In malignant tumor, the mitotic rate is high. Here's a lump of cells or a tumor. This contains neoplastic cell. The neoplastic cell enters mitosis and divides. The number of cells entering mitosis per unit time is mitotic rate. In a benign tumor, the number of cells entering mitosis per unit time is less as compared to malignant tumor. That is why the rate of growth of benign tumor is less as compared to malignant tumor. Another way of looking at it is, let's say here's a lump which grows double in its volume. The time taken for it to grow double in its volume is what we call volume doubling time. Since in benign tumor the mitotic rate is low, it takes longer for it to grow, so it has a much higher volume doubling time. Since in malignant tumor the mitotic rate is high, it takes a much less time for it to grow, so the volume doubling time is much less. Second is clinical feature. A patient with benign tumor is usually, most of the time, asymptomatic. But a patient with malignant tumor is symptomatic, and the symptoms are the same that are seen in cancer, because at the end of the day, malignant tumor is cancer. However, there are exceptions. There are benign tumors that show serious problems as well. For example, during non-invasive meningioma or benign meningioma. See, here's your brain, and the brain is covered by a layer called meninges. There's your pia mater, arachnoid matter, and dura mater. The benign tumor of the meninges is what we call meningioma. Usually, meningioma is asymptomatic. It does not cause any problem. But sometimes what happens is that the meningioma of the meninges covering the brain becomes so severe that it starts pressing the blood vessels around the brain. So there are blood vessels and nerves present around the brain or at the periphery of the brain. These blood vessels and nerves, they get pressed by the meningioma, and this causes severe pain, and this can be really serious. So usually it's asymptomatic, however sometimes it can even be serious. Third is gross feature. If grossly, that is externally, if you look at a benign tumor, it is spherical and encapsulated or present within a capsule, while a malignant tumor is irregular and not capsulated. See, here's your benign tumor which is present within a capsule and it's almost spherical. Here's your malignant tumor which is irregular and it is not present within a capsule. Here's your benign tumor which is present within a capsule and it's spherical. Here's your malignant tumor invading everywhere. This malignant tumor is not capsulated and irregular. Then there's your microscopic features. In case of benign tumor, there is high differentiation. What is differentiation? See, differentiation is the resemblance of a normal cell with its corresponding neoplastic cell. That is, if you take a normal cell and the neoplastic cell of that normal cell and then observe the two under a microscope, the resemblance between the two is called differentiation. Higher the resemblance, the higher they look alike, that is, the higher the differentiation, the lower the intensity grade of tumor. So as you can see right here, the normal cells, the tumor cells, they look almost like normal cells. So they are well differentiated. As we go from left to right, the cells start becoming undifferentiated. First, we have well differentiated tumor cells, then moderately differentiated tumor cells, then poorly differentiated tumor cells, then undifferentiated tumor cells. As the differentiation or the resemblance starts decreasing, the grade of tumor starts increasing as well. That is, as the grade of tumor starts increasing, the more malignant the tumor is, the more khatarnak the tumor is. Okay, so in case of benign tumor, there is high differentiation. That is, a neoplastic cell looks almost like your normal cell. While in case of malignant tumor, there is lack of differentiation. That is, a neoplastic cell looks nothing like its corresponding normal cell. And this lack of differentiation is what we call anaplasia. And finally, there's your invasion. Benign tumor is non-invasive, as I mentioned earlier as well. As benign tumor grows, it pushes the periphery tissue to the side. However, malignant tumor is invasive. That is, as malignant tumor grows, it penetrates through the tissue and spreads everywhere. But even better than invasion, the defining character is metastasis. Benign tumor is non-metastatic. That is, it does not spread throughout the body, while malignant tumor is metastatic. If a tumor is metastasis, there is no question at all. If it is metastatic, it's malignant. The whole point of it being called malignant is because of its property of metastasis. Finally, treatment. So what's the point of knowing whether a tumor is benign or malignant? The point is that after you have determined whether the tumor is benign or malignant, you can follow it with appropriate treatment. If the tumor is benign, you can simply surgically remove it. But if the tumor is malignant, then even after surgery, you have to follow it with chemotherapy, radiotherapy, targeted therapy, etc. Out of all these differences, there are two that you need to know even in detail. First is microscopic features. What exactly do you mean by having higher differentiation and lower differentiation? And what are the various characters of anaplasia? And number two, metastasis and invasion. What's the difference between invasion and metastasis? Both of them in a sense means spread. That is, spreading of tumor is invasion and the spreading of tumor is also metastasis. So what's the actual difference and what's so significant about metastasis? Here are the various microscopic features that distinguish between benign tumor and malignant tumor. So this right here is benign tumor, which is encapsulated and spherical, and here's malignant tumor, which is irregular and non-capsulated. Let's look at the microscopic features. The first is basal polarity. If you look at the cell of benign tumor, you'll find that the nucleus is placed at a certain pole or at the base of the cell. So it shows basal polarity. However, in case of a malignant tumor cell, the nucleus is not present at a certain corner. So basal polarity is absent. Second is pleomorphism. All the neoplastic cells of benign tumor look alike. That is, there is no variety of morphology of the cells. However, in case of malignant tumor, the cells, they are present of variety of types. That is, they don't look alike. There is variety in the morphology of the cells. So pleomorphism is present in malignant while absent in benign. Nucleus to cytoplasm ratio. If you look at the cell, you'll see that the nucleus content is very less as compared to the cytoplasmic content. So low divided by high, the ratio comes out to be low. So nucleus to cytoplasm ratio is low in benign tumor. However, in case of malignant tumor, the nucleus is quite large and takes a large space in the cell. So the nucleus to cytoplasm ratio in malignant tumor is high. Then N-isonucleosis. In benign tumor, all cells contain nucleus that look alike. However, in case of malignant tumor, all cells contain variety-shaped nucleus. That is, there is absence of similar morphology of the nucleus or same looking nucleus. That is N, absence, iso, same, nucleosis, shape of the nucleus. Since the shape of the nucleus is different in different cells, N-isonucleosis is present in malignant, however absent in benign. Then nuclear hyperchromatism. The DNA in the cell is present highly condensed in case of malignant as compared to benign. There is higher density of DNA in malignant as compared to benign. So upon staining, the nucleus comes out to be more vibrant in malignant as compared to benign. That is why nuclear hyperchromatism is present in malignant but absent in benign. Then prominent nuclei. Malignant tumor cell has a prominent nuclei. However, the nuclei is not that prominent in benign tumor cell. Abnormal mitotic figure. The mitotic figure are present normally in benign. However, they are present in variety of axes in malignant, so it is abnormal. Giant cells. Giant cells are large cells that contain multiple nucleus and it is not present in benign. However, it is present in malignant. So one last revision again. So basal polarity is present in benign but absent in malignant because the nucleus in benign tumor cell is present at a certain pole at the base of the cell, but the nucleus in malignant tumor cell is not present at a certain pole. Pleomorphism is present in malignant but absent in benign because the cells of the malignant tumor, they don't look alike and there are variety shaped cells. However, in benign tumor, the neoplastic cells, all of them almost are same shaped. Nucleus to cytoplasm ratio. In case of benign tumor cell, the nucleus is small, so the nucleus to cytoplasm ratio comes out to be low. But in malignant tumor cell, the nucleus is large, so the nucleus to cytoplasm ratio comes out to be high. N-isonucleosis. In case of benign tumor, all cells, they contain nucleus of the same shape, or the nucleus of the cells of the benign tumor look alike. However, in case of malignant tumor, the nucleus of the cells, they don't look alike. That is, there are variety shaped nucleus. So they show N-isonucleosis. The DNA in malignant tumor cell is present at a higher density as compared to benign tumor cell. So malignant tumor cell shows nuclear hyperchromatism. In malignant tumor cell, the nuclei is present more prominently as compared to benign tumor cell. So prominent nuclei is present, prominent nucleoli is present in malignant. The mitotic figure, so the figures that show where mitosis is going on, is present normally in benign tumor but abnormally in malignant tumor. Giant cells, which are large multinucleated cells, are absent in benign tumor but present in malignant tumor. After microscopic features, the better determining character is invasion, and following that is metastasis. See, invasion and metastasis. If a tumor is showing invasion, then it is 100% malignant. If a tumor is showing metastasis, then it is 100% malignant. Both invasion and metastasis refers to the spread of the tumor. But if you had to choose between invasion and metastasis, then metastasis is a more defining character. That is, if metastasis is seen, then for sure the tumor is malignant. And another question is, if both invasion and metastasis refers to the spread of the tumor, then what's the difference between the two? This is the difference. Let's say a certain cell in your liver all of a sudden, maybe due to mutation, becomes cancerous. This cancer cell proliferates and grows in number and forms a mass of cell. This mass of cell is what we call a primary mass or a primary tumor, since this is the first tumor or first mass that is formed. Now this primary mass, it spreads everywhere. It spreads everywhere by penetrating through the tissue. Like for example, the mass spreads into the gallbladder. It spreads into the pancreas. It spreads into the common bile duct. But during the spreading process, there is continuity in the mass. There is continuity in the mass. This kind of local continuous spread is what we call invasion. Let's say certain cells from the mass break off and enter the bloodstream, or maybe your lymphatics, or maybe a body cavity like abdominal cavity where the liver is present. And from there, the cell that has broken off from the primary mass reaches somewhere else, settles there, and forms a new tumor there. Maybe it reaches the lung and then forms a mass there, or maybe through the abdominal cavity, a piece of primary mass reaches the stomach and then forms a mass there. This mass, which is formed secondly, is what we call secondary mass or secondary tumor. Now the difference between invasion and metastasis is that in invasion, there is continuity in the spread and the spread is taking locally, that is at a smaller distance. However, in metastasis, there is discontinuity. A piece of primary mass, it breaks off and then travels a long distance to reach some other organ, implant there and form a secondary mass. So that's the difference between invasion and metastasis. Again, invasion is a local continuous spread. There's your tumor or a mass that spreads. During spreading, it does not break off. That is, there is continuity in the spread. This is your invasion. But let's say a piece of this mass breaks off, travels either through bloodstream or lymphatics or body cavity and reaches somewhere else, implants there and then forms a secondary mass. That's your metastasis. Let's look at metastasis in detail. Here's organ 1. Organ 1 contains primary mass. From this primary mass, cancer cells, they break off and they enter either your blood vessel or lymphatics or body cavity. Through blood vessel or through lymphatics or body cavity, these cancer cells, they reach organ 2. In organ 2, the cancer cell implants itself and then starts proliferating and forms a secondary mass. This whole process is what we call metastasis. Metastasis is the characteristic feature of malignant tumor. That is, all malignant tumor shows metastasis, except, you have to remember, except glioma and basal cell carcinoma. Basal cell carcinoma and glioma, both of them are malignant tumors, but they do not show metastasis. Okay, so from this particular diagram, you might have already figured out the roots of metastasis, or the roots through which the broken cancer cells from the primary mass reaches somewhere else, settles and forms secondary mass. So the first route is through blood vessel, which is called the hematogenous spread. The second route is through lymphatics, which is called lymphatic spread. And the third route is through body cavity, which is transcoelomic spread. First, let's look at lymphatic spread. Malignant tumor, it is of two types. It's either a carcinoma or a sarcoma. Carcinoma, it metastasizes by lymphatic route, and sarcoma, it metastasizes by hematogenous route. Again, malignant tumor, two types, carcinoma and sarcoma. Carcinoma metastasizes by lymphatic route. Sarcoma metastasizes by hematogenous route. First, let's look at carcinoma, which metastasizes by lymphatic route or lymphatic spread. Let's take an example of carcinoma. Here's a breast. The breast contains 4 quadrants. Among the 4 quadrants, this is the outer upper quadrant, which is the most common region where breast carcinoma is seen. So here's your primary mass or breast carcinoma. From this primary mass, cancer cells, they enter lymph vessels, supplying the breast. From there, they travel through lymph nodes and then spread to different parts of the body. The cancer cells, they can enter your humerus and cause bone cancer. They can enter the other breast and cause the cancer of other breast. They can enter your liver through the abdominal route of lymph vessels and cause cancer there. But it's not just the organs. Even the lymph nodes, they get affected. For example, the lymph nodes that come in the way of cancer travel or metastasis of cancer cells get affected as well. Let's say few cells from this primary mass, they enter the lymph vessel. From the lymph vessel, they reach these axillary nodes. The cancer cells, they settle in the axillary node, proliferate there, and this can lead to the swelling of the axillary node. Sometimes these swelling are palpable from outside as well. The first lymph node that gets affected is the sentinel node. Again, the first lymph node that gets affected by the cancer cell from the primary mass is called sentinel node. The second is hematogenous spread, which is mostly seen for sarcoma. During hematogenous spread, the cancer cell, it spreads through blood. But there are two types of blood vessels, arteries and veins. So which is preferred for hematogenous spread? Cancer cell prefers vein over artery. The reason being, vein has a thinner wall. So it is much easier for cancer cell to penetrate through the thin wall and enter the blood inside the vein and then travel from there. The most common organs affected by hematogenous route, or the most common organs where formation of secondary mass takes place by metastasis by hematogenous route, are lung and liver. Here's the reason why. Let's say we have an organ here. This organ contains the primary mass or the primary tumor. From the primary tumor, few cancer cells, they come out. These cancer cells, they penetrate the wall of the vein and enter the vein because they prefer vein over arteries. Arteries have a much thicker wall. They enter the vein. From the vein, the cancer cell through superior and inferior vena cava reach the heart. The heart pumps the blood to lung. So the cancer cell along with the blood enters the lung and then forms secondary mass there, affecting lung or causing lung cancer. Let's say this organ right here is none other than one of the organs from gastrointestinal tract. It may be a stomach or a large intestine or small intestine. Let's say we have stomach that contains a primary mass or primary tumor. Then the cancer cell, they enter the portal circulation. They enter the portal vein. From the portal vein, the cancer cell, they reach liver and then affects the liver, causing cancer there. From the liver, they enter into the vein, which is the hepatic vein, then reaches the heart, and then from the heart, the blood gets pumped to your lung. That is the reason why lung and liver are most commonly affected by hematogenous spread of cancer cell. And even among the two, liver is most commonly affected, and then it's the lung which is second most commonly affected. Third, we have transcoelomic route, that is through body cavity. There are three ways. First, let's say there's your primary mass in the brain. From here, cancer cells, they come out and then they reach the spinal cord, implant there and causes cancer there. The route is through cerebrospinal fluid, which is present covering the whole of central nervous system. Second, let's say there's your cancer cell in the stomach. These cancer cells, they enter the abdominal cavity. Through the abdominal cavity, they reach your ovaries and causes the cancer of your ovaries, or causes the formation of tumor in the ovaries. This is also transcoelomic route because the cancer cells, they metastasize through body cavity, that is abdominal cavity. And the type of tumor that I have given the example for abdominal cavity metastasis is Krukenberg tumor. Krukenberg tumor. So what happens during Krukenberg tumor? During Krukenberg tumor, the primary tumor is present in your stomach. From there, cancer cells, they come out and then travel through the abdominal cavity and reaches the ovaries. In the ovaries, they implant and forms secondary tumor there. This is Krukenberg tumor. Krukenberg tumor is the secondary tumor that is formed in the ovaries by the cancer cells from the primary tumor of the stomach that metastasize through abdominal cavity. And third is the cancer cells can be implanted during surgery. Let's say there's a surgeon who just operated on a cancer patient and the scalpel that he used is not disinfected or it is not sterilized. If he uses the same scalpel during another operation, then the cancer cells can get implanted in the cavity of the patient in that another operation. And that another patient can get affected by cancer. Let's look at the metastatic cascade for hematogenous spread of tumors. Basically, what are the various steps through which a tumor is able to metastasize by hematogenous route? Right here we have a primary tumor. This primary tumor is malignant, that is, it possesses the ability to metastasize. And the route it is going to follow is going to be hematogenous route. So what are the various steps the cell of this tumor has to go through in order to metastasize by hematogenous route? First, there is formation of aggressive cells. So from this bunch of cells, few cells, they become aggressive or possess the ability to metastasize. Number 2, loosening of these aggressive cells. The cells, they are held together with the help of surface protein called E-cadherins. These aggressive cells, they lose their ability to hold one another due to the inactivation of E-cadherins. Number 3, interaction of the tumor cell with extracellular matrix. In between the primary tumor and blood vessel lies the extracellular matrix. The tumor cell, once it loosens, it comes in the matrix and it interacts with the components of the matrix. And these components are laminin, fibronectin, vitronectin, collagen, all those stuff. Once it interacts with the components of the matrix, it releases enzymes such as collagenase and gelatinase. These enzymes released by the tumor cell, it degrades the matrix. Due to the degradation of the matrix, a pathway is created for the tumor cell to follow. The tumor cell finally reaches the blood vessel and penetrates into the blood vessel, which is called intravasation. Inside the blood vessel, the tumor cell is present in a group due to their power of cohesion. This group gets covered up from all sides by the cells of the blood. They are platelets and red blood cells, forming an embolus. The advantage behind this is that this bunch of cells, they are under the target of your immune system. Advantage not for us, but for the cancer cell. The advantage for the cancer cell is that these cells are under the target of your immune system or WBCs. Once they get covered up by platelets and RBCs, these cells are able to evade the immune cells or WBCs. Then they finally reach the wall of the blood vessel at a different site and penetrate outside from there, which is called extravasation. Once they penetrate out of the blood vessel, they are able to form a secondary tumor somewhere else, and there is angiogenesis following that, that is formation of new blood vessels supplying them. So what are the various steps that you need to remember for the hematogenous spread of malignant tumor? First, formation of aggressive clone. Second, loosening of tumor cells. Third, tumor cell and extracellular matrix interaction. 4. Degradation of extracellular matrix. 5. Entry of tumor cell into the blood vessel or intravasation. 6. Formation of tumor cell embolus. Formation of tumor embolus. 7. Evasion of tumor cells from immune cells or WBCs. 8. Penetration of tumor cell out of the blood vessel or extravasation. And 9. Formation of secondary tumor somewhere else. Now let's look at the nomenclature of tumor. There are two types of tumor. There's your benign tumor and malignant tumor. In case of benign tumor, while naming the tumor, you are going to follow the name with the suffix oma, O-M-A, oma. Tumor, be it benign or malignant, it is of two types. It is either of origin from epithelial tissue or it originates from mesenchymal tissue. See, during embryonic development, there are three zome layers. There's your ectoderm, mesoderm, and endoderm. What is epithelial tissue? Epithelial tissue is such a tissue where the cells are arranged very tightly to one another and there is almost no or no intercellular space at all. Epithelial tissue can origin either from ectoderm, mesoderm, or endoderm. If there is a tumor of epithelial tissue, we are going to say that the tumor is of epithelial origin. Second is mesenchymal tissue. In mesenchymal tissue, unlike epithelial tissue, there is intercellular space between the cells. And such kind of tissue is present in muscular tissue, connective tissue, and nervous tissue. Almost all mesenchymal tissue, they are mesodermal in origin, but few such as your nervous tissue, it's your ectodermal in origin. So that's the difference between epithelial tissue and mesenchymal tissue. Okay, so benign tumor. First, let's look at mesenchymal benign tumor. That is benign tumor of mesenchymal tissue. So the benign tumor of lymphocyte is lipoma, of fibroblast is fibroma, of chondrocyte or cartilage is chondroma, of bone or osteocyte is osteoma, of skeletal muscle is rhabdomyoma, of smooth muscle is leiomyoma, of blood vessel is hemangioma, of lymphatics or lymph vessel is lymphangioma, and of meninges is meningioma. Meningioma can either be benign, then we will call it non-invasive meningioma, or malignant, then we will call it invasive meningioma. Okay, that's it for mesenchymal. Epithelial. So epithelial, there are mainly of two types. There are more, but mainly there's your adenoma and papilloma. The part adeno refers to gland. So adenoma has some kind of relation with gland. It is a benign tumor that has some kind of relation with gland. Papilloma. Papillo refers to finger-like projection. So it is such a benign tumor where you will find finger-like projection. Let's look at both of them, adenoma and papilloma, one by one. First, we have adenoma. So adenoma is a benign tumor that is originating from epithelial tissue. So it is benign tumor of epithelial tissue. Now, it can either come from glandular epithelium, that is from a gland. For example, this right here is the epithelium of a gland. And the benign tumor that it has formed is the adenoma of the gland. And this benign tumor is arranged in a glandular pattern. The most significant part here is the glandular pattern of arrangement of benign tumor of glandular epithelium. However, not all adenoma, that is not all benign tumor of a gland, has to result in a glandular pattern arrangement of the tumor. For example, adrenal gland is a gland, but the adrenal cortex adenoma, that is the benign tumor of adrenal cortex, does not give a glandular pattern. There is no glandular pattern present here, but still the benign tumor of adrenal cortex, which is a gland, is adenoma. Secondly, we have non-glandular epithelium. Sometimes epithelium of a non-gland, that is not a gland, can result in a benign tumor with glandular pattern. For example, nephron is not a gland. The epithelium of nephron is not a gland, but the epithelium of nephron, when gives rise to a benign tumor, gives glandular pattern. So we call it nephrogenic adenoma. So for a benign tumor of epithelial tissue to be adenoma, it doesn't have to be necessarily a gland. It can either be a gland or a non-gland but giving glandular pattern. So that's the criteria. Either it has to be glandular in origin, but if it's not glandular origin, then at least the benign tumor must be glandular in pattern. Okay. Second is papilloma. So papilloma, you'll find finger-like projection either microscopically or macroscopically. So this also looks like a finger. Usually, it originates from stratified squamous epithelium or urothelium. This has originated from squamous epithelium, so squamous papilloma. This right here is the result of human papilloma virus. Now let's look at few misnomers. So here are some names that end with suffix oma, but they are not benign tumor. In fact, they have nothing to do with neoplasia or tumor at all. First, we have hematoma. When a blood vessel breaks or ruptures, the blood comes out of the blood vessel and gets trapped in the space of the tissue surrounding the blood vessel. This is hematoma. Again, nothing to do with tumor at all. Next is granuloma. Granuloma is a structure that is seen especially during granulomatous inflammation, which is a type of chronic inflammation. What will you see there? You will see bacteria, which is behind the cause of inflammation. Surrounding that are your modified macrophages called epithelioid cells. And then there are multinucleated giant cells, which are formed of fused macrophages or fused epithelioid cells. And covering all of that is a line of lymphocytes. This is your granuloma, and it has nothing to do with tumor. Third and fourth, you have choristoma and hamartoma. Two important terms. Choristoma. Choristoma is normal cells in normal configuration present at abnormal site. For example, osseous choristoma of tongue. That is the presence of bone in your tongue. So there are normal bone cells in normal arrangement of a bone but present at an abnormal site, that is your tongue. The bone that is present here is absolutely normal. And if you look at it microscopically, you'll find that the arrangement is normal as well. But then the bone is present in your tongue where it is not supposed to be. That's choristoma. Then there's hamartoma, which is normal cell at a normal site but abnormal configuration. For example, here's your spleen, which contains your spleen cells. So there are normal spleen cells present at normal site, that is the spleen. But if you look at it microscopically, you'll find that there is abnormal arrangement of the cells. Then it is called hamartoma. So there's choristoma and hamartoma. Choristoma, normal cells, normal configuration, but abnormal site. Hamartoma, normal cells, normal site, but abnormal configuration. Okay, then there are more misnomers. In this case, these terms, they end with oma, but they are not benign tumors. They are malignant tumor. That is, they are invasive and metastatic. So we have invasive meningioma, melanoma, hepatoma, mesothelioma, lymphoma, and seminoma. Even though all these terms, they end with oma, 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 yet they are not benign tumors, they are malignant tumors. This brings us back to a very important question, and that is, what makes a cell cancer cell? That is, what are the changes that occur at the level of genes in a normal cell to convert it into a cancer cell? For that, first let's understand the activity of a normal cell. Let's say this tissue right here gets injured at this site. The cells at the site of injury, they receive a signal to divide. As soon as the signal is received, the cell starts proliferating, and the proliferating cells, they cover up the wound. As soon as the wound is covered up, the signal is removed and the cell stops proliferating. Simple. Signal is received by the cell, the cell divides, signal is removed from the cell stops dividing. This right here is cell growth control mechanism. And a normal cell division is based on this mechanism. There is a set of genes that are present in a cell that control the division of a cell, or that are behind the cell growth control mechanism of the cell. The problem occurs at the level of these genes to convert the cell into a cancer cell, such that the cancer cell stops abiding by the mechanism, by the rules of the mechanism. That is, even when the signal is not present, the cell will keep proliferating, the cell will keep dividing. Let's first understand these genes so that we are able to understand the complications that occur during a cancerous cell. Okay, let's say all these genes, they are present inside the nucleus of a normal cell. And all these genes, they are either responsible for controlling the division of a cell, or either responsible for keeping the cell alive or dead. Let's look at them one by one. So this right here is a pool of genes. By the way, this represents a pool of genes. This represents a pool of genes. This represents a pool of genes, multiple genes. As soon as the cell receives a signal, usually in the form of a growth factor. So here's a cell, here's the receptor for growth factor, and here's the growth factor. The growth factor attaches to the receptor and it activates a certain pool of genes that is present inside the nucleus of that cell. This pool of gene, it promotes the proliferation of cell or the division of cell. And this pool of gene is called proto-oncogene. As soon as the signal is removed, there is another set of genes that is responsible for stopping cell division or inhibiting proliferation of cell, and that is tumor suppressor gene. So you can compare the activity of these two pool of genes with that of a car. Let's say proto-oncogene is the accelerator of a car and tumor suppressor gene is the brake of a car. Let's say you have to go to a hospital. You get in the car and you press the accelerator so that your car speeds. Let's say you finally reach the hospital. That is, first there was the signal to reach the hospital. Once you reach the hospital, the signal is no longer there. You apply the brakes, and that's your tumor suppressor gene stopping the cell from dividing. Let's say somehow your brake fails or your accelerator fails. Then your car, for some reason, also has a well-trained mechanic in it who is able to solve the problem immediately. That is, fix the accelerator or the broken brake easily. Similarly, in your nucleus as well, there's a mechanic who repairs the proto-oncogene or tumor suppressor gene whenever it gets mutated or maybe gets damaged, and that's your DNA repair gene. Once more, this is your cell. Here's the receptor for growth factor. This is the growth factor. The growth factor binds to the receptor. This sends a signal to the nucleus of the cell, which contains the proto-oncogene. The proto-oncogene, it promotes the division of the cell. As soon as the cell division is over, the signal is removed. Once the signal is removed, there is another pool of genes called tumor suppressor gene that stops cell from proliferating or dividing. Let's say any one of these genes, they get damaged. Then there is another set of genes called DNA repair genes that repairs proto-oncogene or tumor suppressor gene whenever they get damaged. However, in case of a cancer cell, these genes, they get mutated. So what's the problem? Here's the problem. Let's say the accelerator of your car gets damaged and the car keeps on proliferating. Similarly, if proto-oncogene gets mutated, it converts into oncogene. So the proto-oncogene, it gets mutated into oncogene. And the bad thing is that The oncogene promotes cell division or cell proliferation even when the signal is absent. That is, even when you have reached the hospital, even when you have reached the destination, the accelerator still keeps on accelerating and speeding up your car. At that time, what will you do? Obviously, you are going to apply the brakes in order to stop the car. Similarly, you have the tumor suppressor gene to apply brakes to proliferation. However, in cancer cell, even the brakes are damaged. That is, even the tumor suppressor gene is mutated such that it becomes inactive. That means the cell is proliferating even when the signal is not present there. And the proliferation can't even be stopped with the help of brake, even by applying brake. What's the third solution? The third solution is that your car has a mechanic. This mechanic can easily fix the accelerator and the brake. Similarly, your cell, it has a DNA repair gene which can easily repair the mutated proto-oncogene and tumor suppressor gene. However, in case of cancer cell, even the DNA repair gene is mutated such that it is inactive. So basically the mechanic in your car is in a deep sleep forever. So the mechanic is unable to cure your car, fix the accelerator and the brake of the car. So what happens? The car keeps on speeding and you are not even able to brake or apply brake or stop the car by applying brake. But there's one more option. The option is for the car to just blast. If the car blasts, then there won't be problem in the street. There will be problem to your life or the life of the driver as well as the mechanic, but at least the people in the street will be safe, right? Similarly, in cells as well, there are genes that control the death of a cell, and they are your apoptotic genes. The anti-apoptotic gene, they are against apoptosis or against cell suicide, and there are pro-apoptotic genes that are for cell suicide. Let's say these genes, they get mutated. The cell is unable to repair the mutated gene. The cell becomes abnormal. Then the pro-apoptotic gene can initiate the process of apoptosis and the cell will kill itself or commit suicide. Basically, the car will blast on its own and the problem is solved. However, in a cancer cell, even these two genes are mutated. That is, pro-apoptotic gene is inactive and anti-apoptotic gene is active. So even the cell, the cancer cell itself is unable to commit suicide. It will keep on staying alive. The car is unable to blast on its own. That is, it will keep on staying in the position it is in. It will keep on accelerating, speeding, and unable to brake, unable to repair, and keep on accelerating on the road. The cell will keep on proliferating. There is no one to stop cell from proliferating. There is no one to repair the activity. There is no one to kill the cell. Similarly, there's another gene which is called angiogenic factor releasing gene. This gene also gets activated. As a result, angiogenic factors are released. These angiogenic factors, they stimulate angiogenesis or the formation of new capillaries. They supply nutrition to the proliferating cell or the mass of cell or the tumor such that it can receive plenty of nutrition and use that nutrition to divide tremendously. See, there's one more thing. There's your chromosome in the cell, right? The ends of the chromosome, they contain something called telomere. Once the cell divides, the length of the telomere, it decreases. This cell divides and the length of the telomere decreases even more. Till a point comes when the telomere is completely absent or the telomere is completely reduced to 0. At that point, the cell is unable to proliferate even more or divide anymore. There are few cells in our body that has the ability to divide more than others. That is because these cells, they contain genes that form an enzyme called telomerase. Telomerase enzyme, what it does is that it adds to the length of the telomere such that the length is maintained and the cell division can go for a longer period of time. In cancer cell, I repeat, in cancer cell, the telomerase releasing gene is overstimulated to a point the telomere never shortens. The shortening of the telomere does not take place. That means the cell will keep on dividing, its division won't stop. So what kind of cell have we built? Or our job till now has been to build a cancer cell. So what were the various activities we had to do to build a cancer cell? Number one, we had to overstimulate the cell division accelerator gene or the proto-oncogene by mutating it into an oncogene. What oncogene does is that even when this cell is not told to divide, no one is telling this cell to divide, the cell will still keep on dividing. No one has sent signal to the cell to divide, but the cell will still go on dividing. But then there are breaks to stop the cell from dividing. The tumor suppression gene. Even the tumor suppressor gene has been inactivated. So the brakes can't be applied or the cell division can't be stopped. But then there are DNA repair genes, the mechanic who can repair the mutated gene and bring the cell back to normal. Even that is inactivated by mutation. So repair can't be done. Then there are your pro-apoptotic gene that can initiate cell suicide or apoptosis and kill the cell so that the tumor cell or the cancer cell is destroyed. However, even pro-apoptotic gene is understimulated or inactivated, so cell can't even commit suicide. Then there are your angiogenic factor releasing genes that release angiogenic factors which stimulates angiogenesis, which supplies plenty of blood to the proliferating cell so that more cell division can take place. And then there's your telomerase releasing gene that releases telomerase, and this telomerase won't allow the telomere to shorten. The telomere will remain at its original length forever and the cell will keep on dividing forever. So let's revise. This is the final revision. So what are the various things that are going to happen? Okay. In a cancer cell, the accelerator has been overstimulated. That means the proto-oncogene has been mutated into oncogene such that there is overstimulation of proto-oncogene. So there is overstimulation. Let's give an addition mark. Overstimulation. The brakes are failed or the brake fails. That is, the tumor suppressor gene is inactivated. The DNA repair gene is inactivated. The mechanic is inactive. Can't repair the accelerator or the brake. That is proto-oncogene or tumor suppressor gene. Then the cell is unable to commit suicide. So anti-apoptotic genes are activated and pro-apoptotic genes are inactive. Angiogenic factor releasing gene is active so that more and more blood can be supplied to the tumor. Then there's your telomerase releasing gene, which is also active so that the telomere does not shorten and the cell can keep on dividing forever. With this information, you will easily be able to figure out the hallmarks of cancer cell on your own. So the first hallmark, the cell divides whenever, even if the signal is not there. Even when the signal is not there, the cell is able to divide. Why? Because the proto-oncogene has been mutated into oncogene and the oncogene does not require any signal to divide. It will divide the cell et decay. That is self-sufficient in growth signal. Growth signal is not required. The cancer cell is self-sufficient. Second, there is your division inhibitor gene which stops the division of the cell. This gets deactivated. Since it becomes inactive, the cell can easily evade from growth inhibition. So evasion from growth inhibition. The repair gene, it becomes dysfunctional or inactive. So dysfunctional DNA repair. The pro-apoptotic gene becomes inactive. So suicide or the apoptosis of cell does not take place. Evasion from apoptosis. The telomerase releasing gene is highly active. So the telomere does not shorten and the cell keeps on dividing. So there is limitless replication. Angiogenic factor releasing gene is overstimulated. As a result, angiogenesis is induced at the region of tumor. New capillaries are formed. Obviously, the most typical feature of a cancer cell, invasion and metastasis. Another new thing, this is an extra point under hallmark of cancer cell. Once a cell gets mutated, that is the gene gets mutated, it starts coding for proteins which are mutated as well. Your immune cells are able to detect these mutated proteins and then start killing the cells that are producing these mutated proteins. However, the mutated proteins produced by cancer cells are not detected by your immune cells. So it is able to avoid immune destruction as well. Out of the many genes that get mutated in a cancer cell, there are two genes that you need to know in more detail. There's proto-oncogene and tumor suppressor gene. First, let's look at proto-oncogene. What is proto-oncogene? Proto-oncogene, it is a pool of genes or a collection of genes that code for proteins that are responsible for initiating cell division. So proto-oncogene is your cell division accelerating gene. Proto-oncogene, it is a collection of genes, and these genes, they code for certain proteins, and these proteins are responsible for initiating the process of cell division. Now, first let's look at the activity of proto-oncogene in a normal cell, then we can compare it with that of the cancer cell. In a normal cell. So here's a normal cell. On the surface of the normal cell, we have growth factor receptor. If the growth factor receptor gets growth factor, that is binds with the growth factor, the proto-oncogene becomes active and the cell division is initiated. But let's say the growth factor does not receive any, the growth factor receptor does not receive any growth factor, then the proto-oncogene is inactive. The tumor suppressor gene, which is cell division breaking gene, is active. As a result, cell division does not take place. However, in case of a cancer cell, the proto-oncogene is mutated into oncogene such that there is overstimulation of the gene. So, such a mutation should take place that is going to increase the activity of the proto-oncogene. That is, oncogene should have activity much more than proto-oncogene. And such a mutation is either a gene mutation of proto-oncogene or chromosomal translocation or gene amplification. These mutations, they convert proto-oncogene into oncogene, leading to the overstimulation of the gene. Proto-oncogene is found in a normal cell, and its activity in a normal cell is to initiate cell division whenever it receives a physiological signal like growth factor. On the other hand, oncogene is present in a cancer cell and it is self-sufficient. That is, even when the cell does not receive any signal, the oncogene is still active in order to carry out the process of cell division. There are 5 major groups of proteins that proto-oncogene codes for, and these 5 major groups of proteins are responsible for initiating the process of cell division. Let's look at each of them. First, we have the proteins that are responsible for stimulating or providing message for cell division, and those are your growth factors. Growth factors are the signals of cell division. Then there are receptors on the surface of the cell called growth factor receptors that receives or binds to growth factor. Once the growth factor binds to growth factor receptor, the signal from the surface of the cell is sent to the nucleus with the help of a protein called signal transducing protein. So these proteins, they transduce the signal from the surface of the cell to the nucleus. Once the signal is reaches the nucleus. The process of transcription starts and it is regulated by nuclear transcription factors. The whole cell cycle is regulated by cell cycle regulators. So these are 1, 2, 3, 4, 5 major group of proteins that are responsible for initiating cell division. Each group have their examples down below. So among all these proteins, I'm going to show you RAS in more detail. So in a normal cell versus what happens in a cancer cell. So let's look at the function of RAS in a normal cell, and then we'll look at the function of mutated RAS in a cancer cell, so that we are able to compare the mutation, the activity of proto-oncogene in a normal cell and the activity of mutation in proto-oncogene in cancer cell. Okay, first we have the normal cell. Here is the growth factor receptor, which is attached to signal transducing protein called RAS. This RAS is inactive and it is associated with GDP. As soon as the growth factor receptor receives growth factor, the GDP gets converted to GTP and the inactive RAS becomes active. This active RAS contains GTP, and the active RAS now follows various pathways to initiate the process of mitosis. Then what? So there's your active RAS, there's the growth factor in growth factor receptor, the active RAS initiated the process of mitosis and the cell divided into two. As soon as the cell divides, the growth factor is no longer there. That means the cell should now stop dividing. For that, this is what happens. So your protein RAS contains another protein by the name of GAP, which is GTPase activating protein. The function of this protein is to activate GTPase. As soon as the growth factor is gone, after the mitosis of the cell, division of the cell, the GTPase activating protein of the RAS protein gets activated and GTPase becomes active. GTPase, it breaks GTP into GDP so that the active RAS is converted back into inactive RAS. Now, the growth factor receptor has to receive another growth factor in order to re-begin the whole process of cell division or mitosis. This is how the process of mitosis is regulated. However, in case of a cancer cell, the gene out of the pool of genes of proto-oncogene responsible for coding for this protein called RAS is mutated. As a result, RAS itself is mutated. Then what happens? So here's your growth factor receptor. It receives growth factor. The inactive RAS becomes active because GDP gets converted into GTP. Now the thing is that this active RAS is actually mutated. The part of it which is actually mutated is this protein right here. That is the GTPase activating protein is mutated. Since it is mutated or inactive, it is unable to activate GTPase. The whole function of this protein is to activate GTPase activating protein. Since the protein itself is inactive, it is unable to activate GTPase. That means the GTP is never broken into GDP back again. Even when the growth receptor is not there, the GTP is not broken to GDP. That means the active RAS will stay active forever and the mitosis will occur forever. This is how the cancer cell keeps on proliferating even when the signal is removed. The signal is removed, but remember, the protein is mutated. The gap protein is inactive. GTPase will not do its function. GTPase will not do its function. GTP won't be broken down into GDP. The active RAS will stay as it is and mitosis will take place indefinitely. Okay, so here are the various types of RAS proteins K, N, H. The mutations in these RAS protein lead to these corresponding tumors. Similarly, here are the various MYC proteins, which are your nuclear transcription regulating proteins, I think, right? They are your nuclear transcription factors, and mutations in these nuclear transcription factors by these various ways lead to these corresponding tumors. Tumor suppressor gene, it is a pool of genes and it is responsible for inhibiting cell division. So it is basically cell division break genes because it applies break to the process of cell division. It stops cell division. In a normal cell, whenever there is no stimulus, that is, there is no growth factor, the tumor suppressor gene is active and it does not allow cell division to occur. However, in a cancer cell, the tumor suppressor gene is mutated such that it becomes inactive. The type of mutation can either be point mutation or chromosomal deletion. Since the tumor suppressor gene is inactive, there is no one to apply brake to the process of cell division, and the cell division will keep on taking place. Here are the various types of tumor suppressor gene. These are the four main types: RB, P53, APC, TGF beta, and then there are other types as well. And then here are the associated tumors related with the mutations of these genes. Carcinogenesis. Carcino means cancer and genesis means generation. So the generation of cancer cell from a normal cell is carcinogenesis, or the process of generation of cancer cell from normal cell, or the process of conversion of normal cell into cancer cell, that's carcinogenesis. Normal cell gets converted into cancer cell due to mutation, and this mutation is brought about by various substances that has the ability to cause cancer. And these substances that possess the ability to convert a normal cell into cancer cell through mutation are called carcinogen. So there are two terms. Number one, carcinogenesis, that is conversion of a normal cell into cancer cell, and carcinogen, the substances that bring about carcinogenesis. There are three types of carcinogen and their corresponding carcinogenesis that you need to know: chemical carcinogen and chemical carcinogenesis, radiation carcinogen and radiation carcinogenesis, biologic carcinogen and biologic carcinogenesis. Chemical carcinogen, there are two types, either direct or indirect. First, let's look at chemical carcinogenesis. The whole process of chemical carcinogenesis is divided into three parts: initiation, promotion, and progression. Under initiation, the normal cell is going to be first converted into cancer cell. So there is initiation of carcinogenesis. Under promotion, the cancer cell is going to promote itself by dividing and proliferating. And under progression, the cancer cell is finally going to form a tumor such that it brings about the symptoms of a cancer. So you'll find cancer phenotype. First, let's look at the initiation of chemical carcinogenesis. Let's say your blood contains a chemical carcinogen. If this chemical carcinogen is direct, then it can directly affect your cell, your normal cell. But if it is indirect, then first it has to be activated. In the liver, the indirect chemical carcinogen gets activated into active chemical carcinogen by metabolism. This is called metabolic activation. After metabolic activation, the active chemical carcinogen can finally affect the cell. Inside a normal cell, this is what happens. Inside the normal cell, the chemical carcinogen loses an electron and becomes an electrophile. So the chemical loses electron and becomes an electrophile, and the electrophile is positively charged, while the DNA present inside the nucleus of the normal cell is negatively charged. The positively charged electrophile binds with the negatively charged DNA. As a result, the DNA becomes mutated and the normal cell gets converted into cancer cell. And this is the initiation of chemical carcinogenesis. The cancer cell then proliferates and increases in number, basically promotes itself, and then finally show cancer phenotype and form malignant tumor, which is progression. These are the various direct and indirect chemical carcinogens and their associated cancer. Okay. Second up, we have radiation carcinogenesis. Carcinogenesis brought about by radiation. The radiation, it is of two types. You have either ionizing radiation or non-ionizing radiation. Under non-ionizing radiation, there are UV rays that are produced by sun or that are present in your sunlight. There are three major types of UV rays. UV rays A, B and C. Out of these three types, UVB is bad. That is, it possesses the ability to bring about carcinogenesis. While in case of ionizing radiation, you have X-rays, alpha rays, beta rays, gamma rays, protons, neutrons. Now, the cancer brought about by UVB rays are that of your skin. And in your skin, it can either be squamous cell carcinoma, basal cell carcinoma, or melanoma. While ionizing radiation can bring about all kind of leukemia except the CLL type, all type of thyroid cancer. Along with that, you can have skin cancer, myeloma, lung cancer. Let's look at the mechanism of this and then this. Mechanism of non-ionizing or UVB radiation. Again, B for bad. Here you have DNA of a normal cell where the purine is with a pyrimidine. Once the UVB radiation affects the DNA, the formation of pyrimidine dimer takes place. That is, at the same place you'll find two pyrimidine together. That means the DNA is mutated and the normal cell is converted into cancer cell and the carcinogenesis has taken place. Next up, mechanism of ionizing radiation. So this can take place two ways. Either the ionizing radiation is going to directly affect the DNA and cause the mutation of the DNA, or the ionizing radiation will affect the water molecules in the cytoplasm of the normal cell. The water molecules will get broken down into free radicals and reactive oxygen species like peroxide and such. And these reactive species, they are obviously going to react with the DNA of the normal cell, such as the mutation of the DNA takes place and the normal cell gets converted into cancer cell. Finally, third type of carcinogenesis, and that is microbial carcinogenesis, which is brought about by microorganisms such as bacteria, or it can be brought about by virus. And the viruses that can bring about carcinogenesis of a normal cell are called oncogenic virus, which you'll learn in more detail in microbiology. But for now, here are the various oncogenic virus, your DNA oncogenic virus and RNA oncogenic virus, and their associated malignancy. Okay. Finally, a small topic, that is tumor markers, which again you are going to see in detail under biochemistry. But for this topic, you need to know this much. Tumor markers are the substances that are produced by either tumor cells themselves or by normal cell in response to tumor cell. So it is only when the tumor cell is present inside your body that these markers are produced either by the tumor cell themselves or by the normal cells in response to the presence of that tumor cell. What's the significance of tumor markers? The significance is that by measuring the level of these tumor markers, you are able to diagnose the presence of the tumor. So it helps in pathologic diagnosis by detecting the amount of tumor marker in body fluids or tissue. Here are the various types of tumor markers and the associated tumors they are seen in. So the tumor markers of their associated tumors. And with that, we complete neoplasia.